if you're on. If you don't mind helping me admit folks, I would appreciate it, and muting. That would
I,
help a lot.
I can help you, Meredith.
Okay,
Hi.
thanks, Alicia.
Good morning, everyone.
So thanks for jumping on today. As you see on the screen here, we're going to talk about the assisted living service updates. We have lots of details to go over with you today. So I appreciate you taking the time to jump on. If there are folks who were not able to make it, obviously we are recording this presentation and I will be able to send it out or put it on the WAN shortly after the presentation is over. I will also share the PowerPoint from today's presentation. In the invitation invite through Teams, you should have received a copy of the service rule as well as the notice that we issued earlier this week. So feel free to pull those open, make notes as we go through the presentation today, because there's going to be some of the slides that refer back to the notice. And so again, I want to make sure that you have everything you need in front of you. During the presentation, if you would so kindly put your questions in the chat, I found that helpful instead of pausing and answering questions throughout the presentation. And then we'll go back at the end and circle back to any of the questions that you have. So before we jump in, and just a heads up for those of you who are on the provider oversight training, there's going to be some repeat information today. But I do want to take a moment to recognize the impact of what's about to happen in January in terms of the rate increase and this memory care service rollout. This is a really significant and important moment for the state of Ohio, particularly for those that we serve. And for the providers. Just to put some of this into context, currently Tier 1 assisted living service is $54.76, while Tier 3 is $76.67. Tier 1 rates are going up to a $137 increase when we look at the rate increase of $130. And Tier 3 rates are essentially going up nearly 70%. So we're going to get into how the tiers are being consolidated and moved into the new basic and memory care service. But this is an important note to bring up just because of the hard work that's been going on with all of you and your advocacy efforts. Certainly our director working with legislators to get this passed for our budget. I just want to take a moment and recognize how big of a deal this is and to thank everybody for their ongoing efforts. Certainly there are going to be some issues that are going to come up with this new service, billing issues. So I ask for your patience and flexibilities. There is this initial rollout that we're going to go over today was intended to ensure that providers could deliver this new memory service and receive that new rate as soon as possible. As soon as CMS approves the rates come January 1, we wanted to ensure that providers had that rate billable in the system. So as we work through some of these kinks and communicate back and forth, I just want you to keep in mind that there are going to be mistakes along the way. That is okay. I expect us all to learn from our experiences, and it can certainly help us inform how we can make better quality of care for the individuals, increase, make a positive policy changes where needed as well. So with that in mind, the agenda, just real quick, Appendix K unwinding reminder, just reviewing some high-level changes to the existing assisted living rule, walk through some of the details with the memory care rule, and review the notice that was issued, and then talk about HCBS. So as a reminder for the Appendix K, I want to circle back to something that was mentioned, I think earlier this week, if not yesterday. But under community transition, moving forward, it will not include items that are required to be provided by the assisted living provider. So the list of those items that providers are required to have in the unit or the room is listed here in 3701-16-15. So, for example, bed linens, waste baskets, towels, basic toiletry items, and paper products are to be provided by the assisted living provider, and Community Transition Services, CTS, will not cover those items moving forward. So if you have a provider who is not providing those required items per rule, we are asking that you notify the Department of Health. um, Please copy your PAA provider oversight staff for their awareness, so that they can provide technical assistance, or even reach out to us at ODA if it's a problem that they need help with. So there are two ways to contact health when you come across these issues. There's that 1-800 number listed there, and then the complaint form. Now, if you go onto the Department of Health's website and you search for the complaint form, you'll be able to find it there. I realize that link might not work on the PowerPoint. I will double check that. So again, just keep that in mind as you're working with consumers. And if you have any questions about that, please feel free to let us know if you need any help. So let's switch to the new service rule. The assisted living service rule is going to include the memory care service. So it's all one rule, and it's 173-3902.16. So again, that's the rule that was attached to the meeting invitation. So the assisted living service rule is going to also include both certification types. I'm sorry, yeah, 3 certification types: either basic assisted living certification, just the memory care certification, or both. The certified memory care providers are going to have to comply to all of the basic requirements and then the additional memory care requirements. We already had a training for provider oversight staff that went into more detail about that, but I just thought I would share that information with you in case you had any questions. The definition of what memory care or the memory care service is in the rule, and it is a service that a provider provides in compliance with paragraph D, which is the memory care service portion of the rule, to an individual with a documented diagnosis of any form of dementia. Going through some other updates to the assisted living rule, we have a lot of questions about the updated lock language, so we wanted to review that. The resident unit has a lock that allows the individual to control access to the resident unit at all times unless the individual's person-centered service plan indicates otherwise. Currently in the rule, to have a lock removed from a unit requires a physician's order, and it has to be documented in the person-centered service plan. Moving forward on January 1, if a lock needs to be removed from an individual's unit door for their safety reasons, for medical reasons, you do not need a physician's order, but you still have to ensure that the person-centered service plan reflects that modification, which is a requirement per the rule, and that all of the necessary components for the modification are reflected in the care plan. So going back to the training that we issued in a notice, I think it was August or September, for HCBS setting requirements and person-centered care planning, there were components of that training that talked about what you need to put in your care plan when a modification is required. So this would be an example of a modification where you are removing the lock from the door, and you would have to represent that in the care plan. There are other updates in the basic assisted living rule that are minor, that do not impact processes, but it was just to clean up the language. So I just wanted to note that as well. So let's talk about the memory care service itself. So these are the standards that are required. I know that this isn't clinical related necessarily, but I want you to know what the rule says so that when you're talking with folks who may have questions, you have a sense of what's being included in this service. So providers are going to add a purpose statement on their website about this memory care service if they are certified to provide it. The provider is designating the single occupancy resident unit of this rule to be a standalone memory care unit, a memory care unit in a memory care section of the RCF, or a memory care unit in an RCF of a provider that provides only memory care. Now, to break that down, because that can be a little confusing, what it means is that the memory care service can be delivered anywhere within the setting. We are allowing providers to decide where they want to deliver the service as long as they meet these requirements, and that service is only being delivered to individuals with a documented diagnosis of any form of dementia. So there have been lots of questions about whether this service is delivered on locked or secured units or not. And this portion of the rule is essentially saying that providers can decide where they want to provide that locked unit or not. This flexibility exists for providers to make that decision for their business and how they want to operationalize this. Another standard is that providers have to arrange for at least 3 therapeutic, social, or recreational activities as outlined in the rule here, with consideration given to individuals' preferences and designed to meet individuals' needs. Currently, the basic service for assisted living requires that the provider arrange or provide for activities, but it does not specify the amount or the frequency of those activities occurring throughout the day. So for memory care, the provider has to demonstrate that there are at least 3 a day. So that's an additional requirement for those providers. Additional standards include that the provider ensures safe access to outdoor space for individuals. So safe access to outdoor space is going to mean something different for each provider. Each provider is going to demonstrate compliance with this rule based on their physical setting, based on the preferences of the individuals. So your job as case managers is going to include ensuring that preferences on how frequently they want to go outside, what time of day they want to go outside, uh, et cetera, are reflected in the care plan so that the provider is aware of how the individual prefers to spend time outside. We're going to get into that later in the presentation, but for your purposes, it's essentially defining the preference of outdoor time for the individual. The provider assists each individual who makes a call through the resident call system in person in fewer than 10 minutes after the individual initiates the call. Again, provider oversight staff are going to be monitoring compliance with that, but please just, to the degree you can, inquire with individuals, inquire with other natural supports and families, and ask if individuals are having that need met. When you do your in-person quarterly visits, just posing that question can help also give us a sense of whether a provider is able to meet this need or not. There are additional staff requirements in the rule, but I didn't want to spend time getting into that. You can look at it when you get a chance. So let's move on to service code and rates. So the basic service code is going to be the T2031U1, which is currently our assisted living tier 1. And then the memory care service code is going to have that U3 modifier, which is our tier 3. So basically we've consolidated into 2 tiers or 2 services, and we are eliminating the tiered language, the tiered codes, effective January 1, again, pending CMS approval. The basic rate is going to be 130 and the memory care rate is going to be 155 a day. So transitioning to the notice and the work that has to be done in the service plans. The update to PIMS for the new basic rates, the memory care rates, is going to happen over the weekend of December 15th. So we are asking that all assisted living consumers are checked in PIMS by close of business December 15th, 2023, so that ISD can make these updates in PIMS by December 18th, 2023. We are going to send you a list of certified memory care providers, and we are asking that from that provider list, you then identify individuals who have a verified diagnosis of dementia in PIMS. That list of individuals is then going to need a manual service plan update for the memory care service. Unfortunately, we could not find a way to have PIMS take care of that for you. And this is kind of a big push, and this is unique to this rollout. It will not be ongoing moving forward. But to get this initial rollout, we need you to look at that list that I send you on a weekly basis. Right now, there's about 45 providers who have requested this memory care service. And I will start emailing that list out next week. So take that list, review the individuals, and identify those that have a documented diagnosis of any form of dementia. You will find that in PIMS. You see that highlighted on the right within your medical information tab in the diagnosis tab. There's essentially two phases to the work that you're going to need to do in adding the memory care service into the service plan. So beginning that Monday, December 18th through the rest of that year, that's when you will add the service plan for those individuals that you identified from the list. That means that providers can bill for the memory care rate beginning January 1. All the while, I will be continuing to collect these memory care attestations from providers, and we'll continue to update that list so that starting in phase 2, January 16th, you'll be able to add the memory care service plan for individuals identified on the updated list so that providers can bill beginning January 16th, 2024. Now, all of this initial rollout is going to end by January 15th in terms of providers being allowed to attest to delivering this service. We wanted to build in a little bit of a buffer so that if there are a few stragglers, we could manage those. But this, again, is a unique and onboarding process for getting this service authorized. And moving forward, providers who did not submit their attestation by the deadline, they will have to apply through their adding of the service process. Again, all of this is in the notice, so please reference that as needed. Again, the notice also said that the tier level form will not need to be completed anymore as of January 1. This is because there's either going to be the basic rate or the memory care rate. And so case managers and assessors will essentially determine whether the individual has a documented diagnosis of any form of dementia. And if that provider is certified to deliver the memory care, then the memory care rate will be added. Otherwise, the basic rate is going to be reflected in the service plan. As a reminder, when it comes to HCBS settings and memory care, the addition of this service doesn't change any of the requirements for the process of ensuring that there's a person-centered service plan in PIMS, or the HCBS setting requirements in the care plan in PIMS. Again, please ensure that your modifications, particularly with this memory care population, we know that there are often modifications for these individuals, that they are documented in the care plan, and that the modification includes each of the components required per the federal rule. And again, we recommend that you use the memory care service rule, the things like activity preferences, outdoor activity or outdoor access. Use that as a guide when developing or monitoring or making updates to the person-centered service plan. So none of the processes or expectations are changing. We just want to emphasize the importance of including these types of um, preferences in the individual's care plan, and that you share that with the provider when the updates are made, at least on an annual basis. So that is it for the content. I cut it short because we had a lot of questions from the provider oversight meeting, so I wanted to leave as much room as possible to do a Q&A section, because I know that that's a lot of information, and I want to make sure that everybody understands what's being asked of them. So I'm going to open it back up to Sarah. If you're on, if you could circle
Yes,
back, that would be great. Thank
yes,
you.
absolutely. The first question in the chat is, would anyone deemed to require 24-hour supervision due to cognitive impairment require the memory care service?
In that situation, we would have to verify that the individual has any form of dementia documented in their medical diagnosis in PIMS. So I don't know how to answer that question, because that would be the first question that I would pose is there a documented diagnosis of dementia, and is the provider certified to provide memory care? If the answer is yes, then the provider can bill for memory care.
Okay, next question. Can we validate the diagnosis using our current PIMS diagnosis, or do we need to reach out for additional official validation?
If the diagnosis is already in PIMS, you do not need to take any additional action. If you have questions about whether somebody does need another evaluation, or needs to speak with their physician about it, then I recommend that you take that step.
Okay, next question. Individuals with dementia, no matter their capacity to be independent, would qualify for the memory unit?
If there's a documented diagnosis of dementia, yes.
And then the next question is similar, that there are individuals who have a diagnosis but are very independent. Are we still going to pay the provider an increased rate?
If the provider is meeting compliance, I'm sorry, if the provider is meeting the requirements per the rule, it's kind of a two-part. The provider can't just bill for the service because they have somebody with dementia living in their unit. The provider has to meet all of those provider requirements, and the individual has to have a documented diagnosis of dementia. Then they can bill. There are likely going to be lots of scenarios where an individual has a documented diagnosis of dementia, but the provider doesn't want to bill or provide that service, and that's okay. So we are doing again, this is unique rollout because we wanted to get the providers the increased rate. So it's a two-part right now. If the provider wants to provide the service and they attest to meeting all of the provider requirements, and they have the individuals with dementia, then they can bill for that service. We had a provider reach out to a PAA who said they have an individual on a secured unit right now, who's on the waiver with a dementia diagnosis, but they didn't want to meet those additional provider requirements. So they wanted to know, do they have to provide that service? And the answer is no, they don't have to. If they choose to opt out, that's their choice. That's okay.
Next question. Memory care doors are locked. Are you saying that they can just have a diagnosis of dementia and still bill for memory care, even though they are not behind locked doors?
Yes. Wherever an individual is living in the facility, locked doors or not, as long as the provider is going to meet compliance with the requirements, then they can provide that service wherever they want in the facility. Now, the chance or the likelihood of providers only providing that service in a particular section, discrete area of the facility, locked or secured area is high. It's likely because it'll be easier to staff for that area. It'll be easier to have those designated activities. But that is the provider's choice. However they want to operationalize the service is up to them. So we are giving them that flexibility.
Next question. Does the case manager have to find out from the facility if they intend on billing for memory care before new codes are established in PIMS?
No, we are taking that step for you. So I am receiving memory care attestations, essentially providers agreeing to meet the requirements, and am going to send the list of those certified providers to all of you so that you can then identify the individuals living there who have a memory care, who have a dementia diagnosis. And those are the providers that will be delivering the service through this ongoing through this rollout, this kind of initial phase. So no, you do not need to call providers. We are working on that with the provider oversight staff and managing that information.
The rule states a single occupancy unit can be certified as a memory care unit. If someone with dementia is in a unit with their spouse, can they receive the memory care unit reimbursement?
Great question. So yes, individuals who have a spouse, who have a roommate, the provider, again, is going to only be able to bill for those individuals with a documented diagnosis of dementia, and that the provider can meet the requirements, staffing requirements, activity requirements, et cetera, for that individual. So if they are living with somebody who doesn't have a documented diagnosis of dementia, then the provider would bill for the basic rate.
Does this impact MyCare Ohio? Will insurance companies be required to pay the new rates, or are they able to negotiate their own payment to AL providers? Meredith, do you want me to take? Oh, go ahead.
That would be great. Nope, go ahead.
So I was just going to say that this would be a decision from the Department of Medicaid and how they write their expectations in their provider agreements. I would see these new requirements as affecting our provider certification. And so if the managed care plan does negotiate their own rate for this service, that would be treated as any other service. So I would say that the ultimate decision for those payment requirements would come from the Department of Medicaid.
Thanks.
The next question, is there a supervision requirement for the memory care service?
Can you clarify supervision requirement? Are you talking about that there are staff requirements? And feel free to unmute yourself if you were the one who asked that.
Leslie, are you able to unmute? Okay, we can move on and come back to that one if needed.
There we go. Okay. So I'm meaning like how right now, if somebody requires 24-hour supervision, we need to document how that is being received. So if, so that they are not able to leave the facility or, be in danger. Is there some kind of requirement similar to that for the memory care service? Or is that just on an individual basis?
Definitely on an individual basis, and I would encourage you to continue to approach it similarly to what you're describing for the memory care service right now. It doesn't, the addition of the memory care service doesn't change that practice of
Okay.
capturing that in PIMS.
Okay. Next question, who determines if they are meeting the criteria every day, 24 hours a day?
The provider oversight staff, and they are going to receive monitoring tools. We are going to be working with them closely in the next 6 months of 2024 to verify that the provider is delivering these services in accordance with the rule. The way we're rolling this out is kind of turning everything we know upside down. Typically, providers have to demonstrate that they've met criteria before they can be certified. We're doing this the other way. We're getting providers the green light to go ahead, and then we're going to verify. Again, this is a one-time unique situation, given us the flexibilities that we need to get the rates out. So we will be working with the provider oversight team. If you have providers who have questions, if you have suspicion, concern about providers not delivering that service when you are conducting your in-person visits, please let your provider oversight staff know so that they can investigate.
After the onboarding rollout of ODA finding out what ALs are going to offer memory care service, will Front Door have information regarding those providers so that they can adequately place applicants in those facilities?
So the question is, will you have an ability to track or know which providers offer the memory care service moving forward so that you can refer clients to those facilities? Is that correct?
And this came from Liz. I believe that's correct, but Liz, if you would like to come off mute.
Yes, I would like to clarify that so that assessors can adequately place those members in facilities that offer the memory care services if that's the diagnosis that's present and required.
Yeah, great question. Yeah, absolutely. We will find an avenue to get you that information. We'll talk internally about the best way to get that to you. But yes, we will absolutely get that out.
Okay. For those individuals who do not have a diagnosis of dementia, are we to manually enter the basic service into their service plans by 1/1/24?
No, that will happen for you automatically. So ISD is going to handle the update in the service plans for every individual currently enrolled in the assisted living waiver. They're going to condense all those tiers and have everybody have that basic rate. So when you go in as a case manager and you start to find your individuals with dementia who have the provider that's certified to deliver the memory care service, you will see that basic rate. Hopefully the timing might be a little bit different, but then you will add that memory care rate. I'm sorry, the memory care service authorization to that service plan, but you do not need to make the adjustment for the basic rate. That will already be done. So if you, just to add a little bit more, so if you have no individuals on your caseload that are residing at any of the facilities, there's no work for you to do with this.
If the case manager authorizes memory care and PIMS for an individual with documented dementia, but later learns an AL doesn't want to provide memory care service to this individual, will the case manager need to change the memory care authorization?
Yes, I know that that's a hypothetical, but in theory, if you have a provider who wants to relinquish their memory care certification and they have been providing that service to somebody, you would then change their service to a basic, while the provider oversight staff is probably talking to the provider and figuring out what's going on, what has changed. And so either the provider would say they can no longer care for the individual, and maybe that means we look for another facility, but that's a hypothetical that we'll cross that bridge when it comes.
Do you anticipate that current assisted living individuals who meet memory care requirements will be able to stay in their current units, or will they possibly need to be moved to other units where memory care requirements can be more readily met? For example, the staffing ratio.
Great question. Our goal in this is to not move anybody. These are their homes. We do not want to do that. So if a provider is intending to move individuals, I want to work very closely with them to find a way to avoid that at all costs. So I think we're going to handle that on a case-by-case basis. If you are having, if you're receiving that concern from your consumers or families, please let the provider oversight staff know, so that they can let us know, and we'll work with the provider and find a solution, because that's our last option, is moving somebody. That's not the first.
And then there was a clarifier. ISD is only adding the base rate, and if the consumer meets memory care, the CM has to delete the base rate and add the memory care service. Is that correct?
I don't know enough about deleting service authorizations. Alicia, do you have thoughts?
Yeah, I just raised my hand. Yeah,
Perfect.
so in this situation, Becky, it's going to be like a blanket change over to the memory care, just like when we change rates, or again, because it's about codes. So everybody will initially on January 1 have the basic code, and and it will carry over. So as you update your memory care people, so again, there is a kind of a tiered method of people identifying themselves as wanting to provide memory care. So it really depends on the facility and when their date is. So if it happens to be later than January 1, you would do it just like any other service. You would end date the basic service and then start the new memory care service on whatever date it is that they actually do it. So so you might have people effective January 1 that, yes, you'll go in and you would have to either delete it or or exit out, basically. I mean, by like end dating it, you could do that, or you could delete it and then add the new line with the correct memory care code and then put the information in. Does that make sense? Okay. All right.
Thanks.
No problem.
Okay, and a couple more just came in, but having trouble viewing them. Okay, here we go. If a consumer with a dementia diagnosis lives in an AL that has been approved to provide memory care, does the assessor or case manager still need to verify that the AL is meeting the memory care requirements specifically for that consumer? How would we verify the 3 therapeutic, social, or recreational activities are being offered?
So the provider oversight staff are going to be responsible for verifying that the provider is delivering those services in accordance with the rule. The job that you have is just ensuring that if you hear otherwise, that you let the provider oversight staff know. But you don't need to take any additional steps to confirm the providers meeting those requirements. Did that answer the question? I want to make sure that that was clear.
Sorry, I thought I just come off mute. Yes, I just, kind of what other people are saying. If someone with memory or dementia is fairly independent, do we ask the AL if they want the increased memory care rate?
And if they haven't attested to doing that already?
Yes, if they're in a certified memory care facility and they have a dementia diagnosis, but they're they don't need any special care because of their dementia is more physical, does the AL automatically get that higher rate?
The AL will get the rate if they attest by January 16th to meeting the provider requirements, and if the individual has a documented diagnosis of any form of dementia. Those are the two things that we are looking for. If the individual has different cognitive needs, physical needs than the other person who has dementia, that is not of issue. It's whether or not the provider can meet those requirements to deliver the service. If you have a provider who is not certified to provide memory care, then they can't bill for the rate unless they add that service before January 16th. Alicia, go ahead.
Yeah. I think what everybody's kind of thinking, and this is my thought as well. Assuming that someone does have a dementia diagnosis or a cognitive deficit, and it's identified, it's documented, and the person lives in an AL that does add the memory care unit. I think what everybody's trying to get around is by default, it seems like that person automatically goes to memory care billing. So I think what everybody's asking, from what I'm thinking myself, like as a case manager, is that if the person has the dementia diagnosis and the facility has this, it's almost like a default, like they automatically get that rate. Is that what some of you are asking? Because that's kind of what I'm thinking is going on. So like Becky just added, would it be the responsibility of the PAA to assign the correct care level? So not necessarily that the assisted living has deleted their memory care, but just if they're saying Mrs. Smith is fairly independent, although she has a cognitive deficit as her primary, and we don't do anything special to her, even though we have memory care, can we still bill or assign her to basic? Is that something that I think is going on? And if not, that's just me asking. So does that make sense, Meredith? I'm sorry.
Just because somebody has a need for memory care doesn't mean they get to bill for it, that the provider gets to bill for it. The provider can only bill if they're going to meet those provider requirements that include higher staffing ratios, faster response times, more activities, all the things that we went over in the rule.
Thank you, because I think that that's kind of been something that's been from all the different questions that I've kind of been noticing. And I think that that's perfect because it is something. And what other people are asking is they keep saying it's about provider, and your answer is about provider oversight. We'll make sure that they're doing this. So I think it's just kind of the checks and balance, but everybody wants to make sure that they are in the right state. And if they have someone that they don't think is really memory care material, that they can advocate for them just being a basic rate. So I think that it's the flexibility and the working it out with the facility is what's kind of behind a lot of the questions. So thank
That
you.
makes sense. Thank you.
Okay, since we do not have to send a tier assignment form to the providers, is there a suggestion on how to communicate the share of cost / patient liability to the providers?
Alicia, do you have an answer? I don't know how to answer that question.
Yeah. So I mean, it would be just like what you're doing right now. You could send emails. Obviously, when people are assigned a rate or the share of cost, I think internally most folks have some kind of form that the Medicaid SSAs do that will, first of all, say what the share of cost is and assign it to the person. So I would say through your traditional methods. The other thing is too, to remember, we're going to put this all on the care plan, right? Because of HCBS settings. So that's also something that we know that every time you update the person-centered service planning, that you're updating with the facility. So hopefully that makes sense. And if it's something that we discover there's a deficit, we can always talk about, again, assigning like certain, Meredith can work with us and we can figure out how to make either a form or something like that. But I think just through your normal communication methods, because you do have so much contact with them, while you're enrolling folks and that sort of thing. So hopefully that answers questions, or that's feasible.
I agree, Alicia. I think when the service plan is provided to the provider, it will have the correct tier due to that's how you build your authorization. And then I know that some PAAs will put the patient liability or share of cost, just like Alicia was saying, either on that service plan in a comment or on the care plan. So I think those already existing mechanisms can absolutely be used.
And if it
Oh,
becomes
go ahead.
and if it becomes an issue, then we can work on something more, but I do think, like Sarah said, I think that'll be fine. So we don't want to add another form to your repertoire unless, it's really necessary. Thanks.
All AL individual records need checked in on 12/15 for the PIMS update. I assume there will be an additional line in the service plan for the 1/1 rate after the update on 12/15.
That is my understanding as well. Yes.
To clarify what Alicia was saying, all tiers 1, 2, and 3, regardless of a dementia diagnosis, over the weekend of December 15th, the code will change to the basic code effective 1/1/24. Then the CM will add the memory care code on a case-by-case basis. Is that accurate?
Yes, it is.
Okay. We also send those tier forms out to family and residents to let them know what they have to pay during RA's change in liability and on new enrollments.
We'll take that back, and if that means that we need to just create the form that looked similar to the tier and just have it say basic and memory with the liability on the bottom, then we can do that. It sounds like that's up for us to look at.
Does an MD have to give the diagnosis of dementia?
I don't have the rule in front of me for that, so I will circle back unless anybody else on from ODA knows.
Yes, well, there's a couple things that kind of go back to level of care too. So if you're establishing someone's level of care and it's the 24-hour 24-hour supervision due to cognitive functioning issues as a primary diagnosis, it probably is already in there. So, we don't really add dementia diagnosis or cognitive diagnosis is until they've been confirmed with a doctor. So if you're doing a first time assessment with somebody, if that's the issue, everything has to get confirmed with their physician anyhow. So it more or less is being done, but you don't have to do like a separate, verification of our folks already in the ALs. And then just like you would with new people, of course, you're verifying that and that will move forward. So hopefully that makes sense too.
To piggyback on a previous conversation, I see that it may be possible for a facility to qualify to provide that service, for example, on a memory care unit, but they may not qualify to provide that service to all individuals with a dementia diagnosis. If a waiver individual with dementia lives on a traditional AL side and that area of the building does not meet the requirements for memory care service, we would not pay the increased rate for that individual.
That is correct.
Okay. Just to confirm, there is no way ODA IT department can identify members with a diagnosis of dementia. We will have to open each individual's file to check. Thanks.
That is correct. And again, this is just a one-time push to get this updated. That will not be the case after January 16th.
And there are no more questions in the chat right now.
Okay. Thanks, Sarah. I imagine there will be more questions as we start to move forward in this process. We will encourage you to send them to ODA. You can send them to the, what is it, Alicia, HCBS clinical
Yes.
Okay.
Yes. Yeah, the clinical mailbox, which is, kind of our primary mailbox for all things clinical and AL and passport. So sure, send them over to us. And then to add to Karen's question about the only way to really look at it is you're going to have to open up everybody's, uh, record and that sort of thing. So just as a comment, I think most folks have specialized case managers that do AL, so it's not like it's necessarily spread around the entire agency. Oh, thanks, Amy, for adding the mailbox. So hopefully it won't be as much of a as a heavy lift that one might think. So I'm hoping that, people can say, oh, and think off the top of their head, well, we know these folks are, and they may have to check a few other people that they're questionable about, but that's just my thought. Again, so it doesn't seem so overwhelming. I hope that that's maybe what pans out happening. And Karen's question, does the diagnosis of dementia have to be a primary? Usually it is a primary. And so Meredith, I'm not sure if the language says it has to be a primary, but it has to be a primary to get someone ILOC by needing 24-hour supervision. So again, that's kind of that initial level of care, entry level, to use that door, because there's a couple different doors to become ILOC, and to use that specific door, that's necessary for the primary diagnosis. And I think
And-
people are just asking about an FAQ, Meredith.
Yeah, absolutely. We'll get one out. Were there other questions that we didn't?
It looks like another question. Since in PIMS, we can use the share of cost liability letter and entering the AL liability and service plan and have consumer provider sign, it is okay to use this to replace the tier level form.
I would say yes. It meets all the functionality, and it's giving the information in an official document to the person. And then it also can be, shared with the AL. I'm not sure that everybody does that. I don't know everybody's actual behind the scenes what they do, but if that's something that is common, that would be a great place too, to maybe not have to add another form. But if it's necessary to add another form, like Meredith said, we can try to make something really simple. But
And then from Liz, it says, and if we have this list, only those individuals will need service lines updated. List being those ALs who are able to provide memory care.
That's correct.
And that should help weed out your people too. If you do a management report in PIMS on your facilities that have AL, then, if you do a census report from that would tell you who's in your census at what facility. So if the facilities in my PAA, there's only 3 that are memory care, then you'd only have to look at those 3. So that would, again, cut down going through your entire caseload list. So that's what Liz is then saying. So we wouldn't need a manual look for each person. This is where my brain goes. So our brains are together, Liz. That's what I'm thinking too. Okay, thanks. And Amy did put our clinical mailbox in the chat as well. So those of you who aren't familiar or just want to double check, look in the chat.
Thank you. Again, this will be shared in the WAN and the PowerPoint will be shared. So continue to look for those emails and updates. And I will be sending reminders on December 15th to get everybody checked in PIMS. And then if you have any questions, we're here to help. Again, we appreciate your understanding and patience through this. We know it's going to be a little clunky, but we will get through it. And thank you so much for your time. If I don't see any of you, happy holidays, and thank you so much. Have a great day.
Bye.